So good evening, everybody. On behalf of MCure Pharmaceuticals, this is Balaji welcoming you for this webinar session on updates from Ias 2022. Once again, we are leveraging technology to bring to your doorstep the salient features of the discussions and the sessions that has happened at the recently concluded Montreal conference. And who best to do that than our own Dr. Sanjay Pujari. And to introduce him for this session, we have my colleague, Dr. Rohan Gurjar. Dr. Rohan Gurjar did his MBBS and then followed it with MSc Pharmacology from the Northeastern University, Boston, and went on to do a PhD in Pharmacology from the University of Liverpool. He has had a stint with the National AIDS Research Institute for a phase 2 trial comparing nevirapine and efavirenz in patients co-infected with HIV and TB. He has had numerous projects assess the pharmacokinetics and genetics of antiretroviral drugs in phase 3 study of NEAT 001 and ANRS 143, which compared a two-drug regimen of darunavir ritonavir plus raltegravir with darunavir ritonavir with TDF-FTC. Currently, Dr. Rohan is working and he's been involved with the clinical development of a novel SARS-CoV-2 vaccine called Gemcovac 19 from our sister company, Genova Biopharmaceuticals, which has recently received an emergency use authorization. Over to Dr. Rohan. Please introduce Dr. Sanjay.
Thank you for the introduction, Mr. Balaji. Next slide, please. So it gives me great pleasure to introduce our speaker for today, Dr. Sanjay Pujari. Dr. Sanjay Pujari is a towering personality in the field of HIV, and I'm sure he needs no introduction. Still, I would like to say a couple of sentences. So Dr. Pujari has done his MBBS and MD in internal medicine. He's a fellow of the Infectious Disease Society of America. In India, he's the director and chief consultant of the Institute of Infectious Diseases in Pune, and also a consultant in HIV medicine and infectious diseases at the Pune Hospital Research Center. He has been the principal investigator of various trials such as Treat Asia and START study at the Pune site. Recently, he has added another feather to his cap by being a member of the ICMR National Task Force on COVID-19. Additionally, he has presented and published more than 100 papers nationally and internationally. And not last but not the least, he is the faculty at numerous symposiums, including the European AIDS Clinical Society Advanced course from 2014 to present. Next slide, please. Next slide, please. Okay, so a couple of housekeeping rules before we go ahead. Firstly, I would request all the audience members to be on mute. Second is, if you have any questions, please type them in the chat box. I'll personally note down all the questions, and at the end of Dr. Pujari's presentation, I'll be asking him the questions and go ahead with that. Okay. So now I'd like to call Dr. Pujari to give his presentation.
Yeah, okay, let me share my screen. Okay, good evening, everybody. At the outset, let me thank MCure for giving me this opportunity to review some of the important presentations from the recently concluded International AIDS Conference, AIDS 2022 at Montreal. So we will look at this in three areas. We'll look at what are the interesting papers in treatment, some of the issues in prevention, and finally look on some of the important comorbidities. So as you all remember, this was a study called NAMSAL, which was carried out in Cameroon, which was a phase 3 randomized controlled trial looking at comparing TDF-3TC dolutegravir versus TDF-3TC efavirenz 400 milligrams. And initially at 48 weeks, there was no difference. The dolutegravir regimen met the non-inferiority criteria. This is extended follow-up, 192 weeks, almost 4 years data, which was presented at the conference. So this is the proportion of individuals with less than 50 copies in ITT analysis. And as you see here, overall, there is no difference between the proportion of individuals with undetectable viral load. But there is some problem in terms of durability of the efavirenz 400 milligrams as compared to this DTG-based regimen in individuals with a baseline viral load of more than 100,000, where there is a significant difference in the proportion of individuals who have less than 50 copies. So the message here is probably DTG has a better durable response as compared to efavirenz 400 milligrams, which is currently being recommended as an alternative ARV regimen in the WHO guidelines. NAMSAL data also looked at weight changes. We know weight changes is getting an important observation across integrase inhibitors. What you see here is obviously in the integrase arm, the weight gain is much more as compared to the efavirenz 400 milligrams arm. And if you see that how many proportion of individuals gain more than 15% of weight, again, it's the DTG TDF 3TC arm, which has more proportion as compared to the efavirenz arm. What is interesting to look at is the slope of this weight gain. You can see most of the weight gain really happens in the first year, and then subsequently you have reasonably stable weight gain or very gradual weight gain happening in either of the arms. So most of this is perhaps in the naive patients, a return to health, and more, of course, being contributed by the integrase inhibitors, or maybe inhibited by the efavirenz 400 milligrams. And the same thing you see here is initially the proportion is very high, the slope is very steep, and later on it kind of plateaus off after 144 weeks. The other trial, which was similarly designed in South Africa, we all know was the Advance trial, which tried to compare efavirenz standard dose with the backbone of TDF-FTC versus TDF-FTC dolutegravir, and also had a third component of TAF-FTC dolutegravir. These were antiretroviral naive patients, and most importantly, at 96 weeks, all the regimens that it was non-inferior, so there was no difference in the efficacy between these three regimens. The non-inferiority criteria of 10% was met. So this is the final analysis of the Advance trial, 192 weeks again, which was presented at Montreal. And these are the virologic efficacy results. As you see here, when you talk about intention to treat analysis, you see not much difference in the proportion of individuals, though you see a lower proportion of individuals with the less than 50 copies in the efavirenz arm as compared to the TAF or the TDF DTG arms. This is more likely because of discontinuation because of adverse events, which constitute failure, and that is something which contributes predominantly to the virologic failure arm. But in an as treated analysis on individuals who are on treatment at week 92, you see no difference in the proportion of individuals. Almost 99% of these individuals are really suppressed on antiretroviral, either of the three regimens. What is interesting is weight changes across week 192, and as is clearly shown, TAF adds an additional layer of weight gain to the DTG arm, followed by TDF DTG arm, and then you have the efavirenz arm. This is more commonly seen or more exaggerated in the female population as compared to the male population. You can clearly see the differences, though the same regimens do not behave similarly in terms of weight gain, but to a lower extent in the male population as compared to the female population. But what I would like you to observe again is the slope. As you see here, the majority of the weight gain happens in the first year, and then the slope kind of stabilizes, and after 144 weeks, it's really plateauing in either of these arms. And so is true with whether it is a male or a female. So it looks like most weight gain is happening earlier on, and then there is a gradual weight gain which happens and subsequent plateauing off after 3 years. This is another way to look at data, because you have clinical significance of obesity defined as a BMI more than 30. And this is looking at the probability of obesity in females and males across the 3 regimens. And again, it's not surprising that you see with TAF DTG, the probability of obesity is much more and faster as compared to efavirenz or TDF DTG. In the male population, it's not really a very great difference that you are seeing, but it's a significant problem in the female population. Now, the clinical consequences of this weight gain is something which is having a lot of controversy. People are looking at cardiometabolic outcomes, people are looking at diabetes, people are looking at CV risk, etc. And we have some data from the advanced studies looking at the prevalence of metabolic syndrome at week 192 and across the 3 arms. And as you see here clearly, the TAF FTC DTG arm has much more metabolic syndrome as compared to the other 2 arms. And it is predominantly more 20%, almost 1 in 5 women who are initiated on a TAF FTC DTG in the African population will have metabolic syndrome. That would really translate into an additional 5 cases of diabetes per 1,000 women treated. So this is an important consequence which needs to be followed up. We still have very unclear data about these consequences. There were some papers looking at increased cardiovascular risk in the first 2 years of integrase inhibitor initiation as compared to non-integrase inhibitor. I didn't cover those abstracts here. But interestingly, some of these papers were showing increased MI, increased myocardial failure, CCF in patients initiated. But of course, these were observational studies, and we need stronger data to make any further conclusion. The other interesting trial which was presented was week 48 analysis of the ANDIS trial, which is again in antiretroviral naive patients without pre-existing NRTI or PI resistance. And they were randomized to a fixed dose combination of darunavir with 3TC. So this is an alternative to your 2-drug regimen of DTG 3TC for naive patients, and comparing it with the standard TDF 3TC darunavir. This was conducted in Argentina, and we have 48-week data which was presented at the conference. And what you can see here is no difference in the viral load proportion of undetectable less than 50 copies by FDA snapshot, whether you look at it as an ITT analysis and in the per protocol population. But what is interesting is in the individuals with a baseline viral load of more than 100,000, you see a slightly smaller proportion of individuals being undetectable in the dual therapy arm. Interestingly, if you look at the lipid changes at week 48, and this is mean change from the baseline in all the lipid parameters, obviously because tenofovir TDF is something which is lipid friendly, you see smaller increases in the 3-drug arm as compared to the 2-drug arm. Where you have a slightly higher increase. Of course, these are very small increases, about 10-20% of baseline values. But of course, triglycerides is statistically, these are all statistically significant actually. But then the clinical translation of these into CV risk is something which needs to be further followed up with. Some data on the long-term efficacy of another integrase inhibitor, bictegravir. This was a pivotal 8990 studies of bictegravir, which compared TAF FTC bictegravir fixed dose combination with either abacavir 3TC DTG or a TAF FTC DTG. And here, of course, this was a 2-drug combination, because this is not available as a fixed dose combination in the world, in the Western world. So primary analysis, we had data up to 144 weeks. Now we have data up to 240 weeks, which is actually an open label extension. And this is one of the studies which has the longest follow-up for an integrase inhibitor based regimen. In the open label phase, including the earlier phase, you can very clearly see whether you look at it as missing equals Z or missing equals failure. The the proportion of individuals with undetectable viral load is quite strong there when you look at it as M is equal to E. Interestingly, resistance emergence based on the criteria for resistance testing. There were 9 patients at the end of 5 years, and you could not detect resistance either to the backbone NRTIs or the bictegravir regimen, reaffirming the status of integrase inhibitors like DTG or bictegravir to have a high genetic barrier to resistance. Again, weight changes over 5 years. You can clearly see this is a weight change every year of follow-up. And again, we see this in the first 2 years. You see a significant weight gain happening, median weight change of plus 3 kgs happening, and then subsequently kind of plateauing off. So looks like from all this data of long-term use of integrase inhibitor that most weight gain is actually happening in the first year or so. And then it is a gradual weight gain which happens and subsequent plateauing off which may happen. EGFR changes, again, not very significant. This is a fall which may actually be also contributed by the inhibition of tubular secretion of creatinine by the integrase inhibitors, and then maintaining the mean change from baseline in the EGFR. So not a very significant problem. In terms of, again, spine and hip, no surprise with any ART really. You have a decline in the initial BMD happening, and then subsequently you have a plateauing. This was also shown in the START study across any ARV regimen, and the same is true with this. Maybe a little more decline happening with tenofovir based regimen, but again it plateaus off after 48 weeks. Another interesting study, which was not a randomized trial but was presented from Brazil, was an observational historical control matched study looking at advanced HIV infection, initiating ART in that context with active AIDS defining condition and a CD4 less than 50. Now, these are really advanced patients. Which is a better regimen for this patient, whether it is an integrase or an efavirenz, was not a very clear question which was answered previously. So this looks at comparing this to regimen at 48 weeks. And as you see here, as far as the proportion of individuals with less than 200 copies or less than 50 copies is concerned, DTG seems to be superior to efavirenz when you initiate them in individuals with advanced HIV disease. In terms of the proportion of individuals who achieve a CD4 more than 200, again, DTG seems to be superior to efavirenz. Of course, there's not much difference in mortality. And in terms of modification of antiretroviral treatment, more modifications in the efavirenz arm, obviously because of the CNS adverse events that we know. So, of course, the sample size of these are small. You can see a 90 to 92, but this is something which is one of the studies which shows that perhaps integrase inhibitors are a preferred treatment option when you want to initiate ART in the advanced HIV scenario. To look at advanced HIV ART initiation in the advanced HIV situation and looking at CD4 recovery, there's a US study which was presented, the OPERA cohort. And as you see here, as compared to TAF FTC bictegravir, when initiated, this had a large sample size. The proportion of individuals who achieved CD4 more than 200 was actually lower in the other arms, including boosted darunavir, dolutegravir, and elbegravir covisistat. So looks like integrase inhibitors are good as far as CD4 recovery of more than 200 are concerned. But this is obviously an observational cohort study. But the important thing is there is absolutely no recovery in the CD4 CD8 ratio in terms of difference between the regimens for recovery of CD4 CD8 ratio. Finally, in the switch situation, there was a pooled analysis which presented for 2-drug regimen of DTG3TC, which was TANGO and SALSA. We know in TANGO, people switched from a TAF-based regimen. In SALSA, they switched from any 2 NRTIs with a PI INSTI or an NNRTI as a core drug. And this pooled analysis looked at week 48 data with a big sample size. What they wanted to see was whether what you start with when you switch, whether it is integrase, NNRTI or PI, and you switch two-drug regimen, whether the efficacy differs versus continuing the same. You see here, there is no difference really in terms of efficacy as defined by a viral load of less than 50 copies. What happens according to the baseline NRTI, if you switch versus you continue the same NRTI, again, not much difference between the two arms. Again, validating that DTG-3TC two-drug regimen is a decent combination. And if you only look at the integrase switch from an integrase inhibitor to DTG-3TC stratified according to the nucleosides, again, you see no difference. So what it really shows is that DTG-3TC in the right patient is a popular, good switch option at 48 weeks. And we have now data for both of these studies for longer follow-up period, 96 weeks and 144 weeks. What is interesting is the mean change in weight, which basically looks at from what you switch. So if you switch from a TAF regimen to DTG-3TC or continue TAF, you really don't see any difference that is happening. But when you switch from a TDF-based regimen to DTG-3TC, you see a increase in the weight in the DTG-3TC arm and continuing to see a plateau in the weight in the TDF arm. What it really shows is the weight inhibition effect of TDF. Once that is removed, you switch to DTG-3TC, the integrase causes the weight gain, and not much difference in the abacavir arm. So here is where you have this idea that TDF-based regimens are perhaps inhibiting weight apart from efavirenz-based regimens. In terms of lipid changes, again, TDF is something which is lipid friendly. TAF may have lipidogenic problems, and you can see here as soon as you switch from a TAF-based regimen to DTG-3TC, you actually have, if you continue your TAF-based regimen, you have slight increase while you have decline in the lipid parameters happening with DTG-3TC. Again, the clinical consequences of this are not very clear. Now, in our clinical practice, as well as in the government, we know people are switching directly from an NNRTI or an integrase inhibitor. And what is the impact on weight? This is an observational study which looks at this, where patients continued with the NNRTI-based regimen versus switching from an NNRTI to a integrase inhibitor, and then stratified according to which integrase inhibitor they are switched to. As you can see here, in both the parameters, more than 5% or more than 10% weight gain. It is more when you switch from an NNRTI to an integrase inhibitor, and it is similar across the three integrase inhibitor regimen. So when you are switching from an NNRTI to an integrase, you should be very carefully monitoring for weight gains and metabolic consequences of the same in this patient more proactively than what we would have done prior to the integrase inhibitor era. Again, this is another study. I'm not going to the details of this, but again, this shows similarly that when you this is a study which actually tries to understand whether you can reverse the weight gain of integrase inhibitor by switching away from the integrase inhibitor. And in this case, again, this is not a randomized trial. This is an observational study where they switched the integrase inhibitor to a boosted protease inhibitor and then measured the weight before and after switching at 9 months and 12 months. And what they really saw was a small decline or reversal in weight, which is happening after switching from integrase to a boosted protease inhibitor. Again, this is an observational study, and I think this is an insurance database study, and you have to be very careful when you try to analyze this. Right now, we don't really know how to reverse the weight gain, which is associated with integrase inhibitors, and we await really more data on that, whether we should be going away from integrase inhibitor or whether we should be adding a weight suppression drug like TDF. All those data is still unclear. Switching gears in terms of neural tube defects on dolutegravir, we have now extended data available from the TSEPAMO cohort. You know, this cohort initially started with an NTD defect percentage of 0.3% in 2021. Last year, it was around 0.15, and now it has come down to 0.11%. Compare with this with the non-DTG conception with non-DTG ART, it's around 0.11%. And if you compare it with efavirenz consumption, again, it's around 0.08%, and women without HIV, 0.06%. So very low levels. And if you actually look at the confidence intervals of these graphs, they're reasonably overlapping with each other. So very low risk and perhaps not a real concern is the issue of NTD. There was more data from other cohorts as well in this conference, which really alleviated the concern that neural tube defects on dolutegravir is something which is a major problem. It's not really. Finally, I'll end the treatment component by showing you the fourth prolonged HIV remission, or so-called cure. The City of Hope patient was a patient who was suppressed on antiretroviral treatment for a prolonged period of time, and then subsequently developed an AML and had a bone marrow transplant with a homozygous delta 32 CCR5 mutation donor, and then was taken off ART. And at this point of time, I think from week 112 to 182, almost 70 weeks, this individual has very no intracellular HIV RNA or DNA post-transplant, but low-level sporadic viremia detected in blood and gut. Western blot is fading in this patient. CD4 count is stable, CD8 count is stable as well. So this is in the fourth so-called cure. The City of Hope patient, which was interestingly presented. Obviously, we know the problems that this can't be scaled up in the population. So to summarize, I think INSTI-based regimens that we are using now very clearly have durable efficacy and may have an advantage in advanced HIV in terms of having a faster CD4 recovery. Of course, weight gain is a concern, particularly in Black females. We also saw most weight gain happens in first year, and then there is a gradual weight gain which is happening and subsequent plateauing off. May have metabolic consequences, especially metabolic syndrome and diabetes, but we need further data on that. And how to reverse that is a holy grail. We really don't have an answer for that. When you want to use integrase inhibitor, particularly DTG3TC as a two-drug regimen, it's a great option for the right patients. And then the neural tube defect on dolutegravir is practically nil. As far as darunavir with the 3TC is concerned, it's another two-drug option which is available for naive patients. But to position them in our clinical practice, is something which is very, very niche. The same clinical caveats for use of apply for DTG3TC apply to darunavir in terms of avoiding it when your baseline viral load is more than 100 copies, avoiding it in the context of active TB, and avoiding it when you are HBV positive. Maybe it can be positioned if you are having an intolerance to dolutegravir, particularly neuropsychiatric events, or if you have a concern for weight gain in your population. But unfortunately, no fixed dose combination like DTG3TC is available for once darunavir, ritonavir with the 3TC combination. Let's switch gears to prevention. And this is not really in the HIV context, but in the STI context. This is one of the important studies presented here. This was an open label trial in the US, which randomized MSMs and transgender women into post-exposure prophylaxis within 72 hours with doxycycline 200 milligrams. And this had two populations. One was the population of no HIV, but were taking PrEP for HIV. Another were people living with HIV. And this trial was stopped by the DSMB because there was a significant effectiveness in both cohort in terms of reduction of incidence of STIs per quarter. And you can see it very clearly here, whether you're looking at gonorrhea, syphilis, overall STI risk reduction was 66% in the HIV negative PrEP cohort and about 62% reduction in the people living with HIV cohort. So this is something which is interesting. Obviously, these have, in terms of antimicrobial resistance, a big issue. This is being debated about, but this is something which is showing you a decline in highly sexually active population, the risk of development of STIs. And perhaps for the first time, you are seeing, apart from the HIV context, an antimicrobial being used as a post-exposure prophylaxis to prevent sexually transmitted infections, particularly gonorrhea and chlamydia. The other interesting study, obviously this is not available in India, but I think as physicians we should know about this, is the use of injectable cabotegravir every 8 weeks as a pre-exposure prophylaxis. Up till now, we were using daily oral TDF FTC. And again, this study was stopped early. The blinded portion of the study was stopped early. And this was because after finding with the DSMB review, because of its efficacy. And as you see here, it's almost an 88% reduction in the risk of HIV infection with injectable cabotegravir taken every 8 weeks as compared to daily oral, or in an unblinded analysis, about 89% reduction in the risk. So huge impact in terms of reduction of HIV infections happening if you are taking injectable cabotegravir every 2 months in a high risk population. And this is what made WHO change its guidelines for PrEP, add this injectable cabotegravir as a conditional recommendation to be offered as an additional prevention choice. And these guidelines were also released at the Montreal conference. So this is something which is important. We should have at the back of our mind once these drugs, whenever they become available. This is an important choice, or at least we should advocate for them to be made available for this condition, for this indication in our country as well. There's another issue of post-exposure prophylaxis. We had not much data. We have been using integrase inhibitors for high-risk post-exposure prophylaxis. This is data looking at TAF-FTC bictegravir as post-exposure prophylaxis in 112 participants. I think this is a Chinese study where they started as after occupational. So this was a sexual high risk post-exposure prophylaxis using once daily bictegravir TAF-FTC, and looking at the tolerability, completion, etc. And of course, this is a small numbers, so no participant was found to acquire HIV in this, but this was not designed for that. But what is important is 96% completed the PEP. Adherence was very good, whether you measured it in terms of self-reported or pill count. So this is a good option. There is some now observational data to use integrase inhibitors fixed dose combination as post-exposure prophylaxis after we had some data for occupational, and now we have for non-occupational post-exposure prophylaxis. Finally, prevention, I need to end by showing you data from the vaccine study. And this is the Imbokodo data correlates of immune protection presented in this conference. At CROI, they presented earlier this year the efficacy data of this vaccine. This is basically a mosaic adenovirus vector 26 vaccine against clade C. And this was something followed up by a protein subunit vaccine, which was alum adjuvanted. And these were healthy women who were randomized to this kind of a dosing schedule. Unfortunately, this vectored vaccine has a very poor vaccine efficacy, 25.2% with a negative lower limit of confidence interval. So this was not very exciting. But then you need to really find out from further blood biomarker analysis, and there was some interesting data on non-binding antibodies of the IgG variety, IgG3 variety for the V1 V2 envelope region of the virus, because in the Thailand trial, remember, in the RV144 they did demonstrate that to be an important correlate of protection. In this study, they similarly looked at it. They looked at multiple correlates of protection. Nothing was really correlating with the immune protection in those individuals who did not get HIV infection in the vaccine group. But they also did not find good correlation with the IgG 3 for the V1 V3. These were, of course, non-binding, non-neutralizing antibodies. So in terms of prevention, I think doxy-PEP is a promising intervention, in particularly in high-risk population of MSMs. But of course, AMR is a major concern, and this is not really practice changing right now, but we need to keep a close eye on the developments in this field. Injectable long-acting cabotegravir is obviously a promising PrEP approach. WHO is already recommending it. The problem, obviously, is the access. And finally, I think HIV vaccines, non-neutralizing antibodies is not a great approach. Now, 3 trials have proven that. So the way forward looks to be inducing broadly neutralizing antibodies, and that's a different talk altogether. Finally, let's end with the comorbidities. The first comorbidity for all of us is tuberculosis, and we all are aware about the practical study which looked at short 6 months regimen of BPAL-M, BPAL-C. BPAL was the standard of care 18 to 20 months for people with RR resistant, rifampicin resistant TB. This was originally in not really looking at HIV, but here in this conference, they presented HIV specific data and compared it with the HIV negative. So this is an all oral 6-month regimen for rifampicin resistant tuberculosis. And in terms of the proportion of individuals with unfavorable outcome at week 42 stratified according to the HIV status, what you see here is in the SOC versus experimental arm, if you compare BPAL-M, BPAL-C or BPAL, there is slightly lower rates of efficacy in terms of this. So the study here, the concern is that perhaps it should be okay for HIV infected patients, but more data needs to be really seen in the long term to look at more numbers, to look at whether the same regimens would work similarly in HIV positive versus HIV negative. In terms of safety, there was no real difference in these two groups. Similar proportion as you see the risk difference here. Another interesting study is we didn't have a randomized trial comparing any antiretroviral regimen for HIV HBV co-infection. So this is a Thailand study which looks at HIV HBV co-infection treatment naive individuals with HBV DNA of more than 2000 IU, HIV RNA more than 500,000 copies, genotypic sensitivity to both TAF, tenofovir and FTC, randomized to TAF FTC bictegravir and TDF FTC dolutegravir. And at week 48, looking at both the HIV response as well as the HBV response. Oh, I think I forgot that slide. Anyway, the slide, I think I missed it somewhere. What it showed was in terms of HIV viral load suppression, there was no difference between these two arms. But in terms of HBV viral load suppression, in terms of liver normalization of enzymes, in terms of HBe antigen loss, as well as in terms of HBsAg and HBsAg loss, TAF FTC bictegravir was superior to TDF dolutegravir. This was very, very surprising. We really don't know what is the reason for this, whether it is TAF versus TDF or whether there is some property of the combined regimen or some property of the integrase. We really don't know. But we know that in mono HBV, there is no difference as far as TDF and TAF is concerned. So we really don't know why TAF FTC bictegravir has a better HBV outcomes as compared to TDF FTC dolutegravir. The other issue is HIV with tuberculosis. Again, we all know the problems with doubling the dose of dolutegravir when you are using with rifampicin. So can you really use dolutegravir with food because it increases the absorption of dolutegravir? Take it once daily with rifampicin. So this is a very preliminary, again a Thai study looking at the PK as the primary endpoint, and the secondary endpoint proportion of individuals with undetectable less than 50 copies. So this is the drug concentration curve. You can see here, obviously, when you combine it with the rifampicin and take it as OD, you are having a lower area under the curve or C trough as well. But as compared to DTG 50 milligram BID. So this is a concern. Obviously, there is a reduction even when you take it with food, when you take it with OD. But what they saw was 90% viral load undetectable, less than 40 copies at week 48 in both the arms. So this calls for a larger trial looking at the strategy of using DTG with food once daily along with rifampicin as compared to BID, which is quite challenging in terms of an additional tablet, etc. for the patients. So there was a phase 2 study, I think this is from South Africa, which looked at randomizing patient. Again, this is a small study looking at TLD plus dolutegravir plus, this is once daily TLD plus placebo. And at week 12, whether it is modified intent to treat or per protocol analysis, week 12 or 24, you see no difference in the rate of proportion of individuals with less than yeah, less than 50 copies. But this is small sample size, again calls for a larger study, phase 3 pivotal study. What is important to perhaps understand is that the CTRF that we are using to say that activity, or the IC90 that we are using to say that the activity may not be really correct for dolutegravir. So maybe in spite of that cutoff, many patients achieving in the drug-drug interaction study, people are still doing fine when they combine this drug with the backbones, having a good virologic success. So that may be the reason why you may get away by giving a OD. Of course, this is again not to be done in practice unless we wait. Oh, sorry. So this is the alliance efficacy 48 HIV HBV. As I told you before, no difference in HIV suppression. HBV DNA lower in the TDF DTG group as compared to TAF. LT normalization lower in the DTG as compared to the TDF DTG as compared to TAF FTC bictegravir, and same is for E antigen loss and S antigen loss seroconversion. So this is what the alliance are. Very surprising results, but we need to really see the publication to understand what the authors discuss as other reasons. And this is a safety, no difference in the safety between these two arms, whether you look at it as treatment emergent serious A or drug related serious A. Finally, COVID-19 and HIV, is there a link between this? This is again extended data from the WHO's database, predominantly 95% coming from Africa, this data, but HIV looks to be an independent risk factor for in-hospital mortality. And as you see here, a CD4 less than 200 is an important risk factor. And other risk factors which we normally see in the population which cause higher mortality is true for HIV: higher age, male gender, chronic kidney disease, diabetes, and hypertension. This further analysis looked at what is the adjusted hazard ratio for this. So 1.5 times more in hospital mortality in HIV positive as compared to negative. If your CD4 is less than 200, the risk is much, much higher. If your CD4 is more than 200, and even if you are having a high viral load, that risk is not very, very high for in-hospital mortality. So again, this is observational reporting with its own limitations. But what it shows is that CD4 is an important component for as far as HIV risk factor is concerned for in-hospital mortality in patients with the COVID-19. So CD4 more than 200 is something which may protect from in-hospital mortality. What was further done was looking at what was the variant predominant during the time that this data was collected, and this is looking at the mortality without HIV, with HIV in hospital mortality, and it is variant proof. So whether it is Delta variant or Omicron variant, adjusted hazard ratio of HIV mortality is higher with COVID-19 in hospitalization. And this is, as I said, irrespective of whether it was Delta or Omicron. Obviously, the effect in terms of the percentage mortality was lower with Omicron as compared to Delta. And we had no data about vaccination status in this study that was presented. Finally, let me end by showing you an interesting study called the Ambition CM. This was presented way back and also published recently, looking at a single dose high dose liposomal amphotericin B along with fluconazole and flucytosine for induction treatment of cryptococcal meningitis versus the standard amphotericin B plus flucytosine. And as you see here, there is non-inferiority, and in fact in the adjusted intention to treat population, there is a superiority of liposomal amphotericin B single dose. So this is the recommendation for treatment of cryptococcal meningitis induction by WHO, which was released during this conference, and they strongly now recommend, this is a strong recommendation for using a single high dose of liposomal amphotericin B with 14 days of flucytosine and fluconazole at this dose 1200 milligram daily up to a maximum should be used as a preferred induction treatment for treating people with cryptococcal meningitis. So this is quite a game-changing thing. So these are some of the implications for practice. I think for RRTB, it's very promising even for HIV to look at using BPAL-M. But of course, we don't have access to these drugs. Bedaquiline, as we all know, is not accessible in the private market. Preliminary promising data for DTG OD with rifampicin, but that really calls for phase 3 confirmatory trials. There are some observational studies from Africa which actually have looked at using DTG OD in patients with active tuberculosis and finding reasonably good virologic success rates. For HIV, HBV, it's very surprising that FTC bictegravir seems to be better than TDF DTG, but we don't know whether it is the TAF over TDF in the context of HIV or something else which is in work there. Especially advanced HIV disease is a risk factor for COVID-19 in hospital mortality for us as physicians. Ensuring no disruption in ART is very critical during COVID-19 times. Patients have been lost to follow-up. Patients have been financially stressed. So we need to really look at how we can keep these patients linked to care and ensure that there is no disruption in ART. And for HIV cryptococcal meningitis, a high-dose single liposomal amphotericin B, 10 milligram per kilogram, along with flucytosine and fluconazole, is a game-changing strategy for induction treatment. So I would like to end by acknowledging these 3 sites. For further reading also, I think all of you can really look at these sites. These have very comprehensive coverage of the conference, and not only this conference, but has a comprehensive coverage on almost all aspects of HIV. So thank you, and I'll be happy to take questions.
Thank you, Dr. Pujari. That was very comprehensive. So let me start by a question of my own. So you showed some data which shows that the weight gain is more pronounced in females than males with TAF TDF. Are there any studies that you know of in the Indian population? And if not, do you expect the difference between female and male weight gain with these drugs to be the same in the Indian population as well?
Yeah, so we have to compare 3 populations. One is the Caucasian population, then we have the African population, and we have the Indian data. Not Indian data, but so-called Asian data. So I think the Caucasian population, there is a weight gain, but that weight gain is not very as intense as the African women. So in terms of absolute weight gain and the proportion of individuals who have more than 5% or 10% weight gain. For the Asian population, I think it is somewhere between. We have analyzed our own data. We tried to publish it. Somehow journal just rejected it, saying that you're not saying anything new. But what we saw really is that the proportion of weight gain is in between the Caucasian and the African population. And it is true that women is an important risk factor. Even in your clinical practice, many attendees here may find more women gaining rapid weight as compared to men.
Okay. So drawing from that, would you suggest to kind of personalize the treatment? So based on the sex of the patient and the weight, would you choose which drug to give?
I would not really think so. What happens in when you actually look at studies is that if you want to look at gender, the proportion is around 20% with metabolic syndrome, as in the African population, as I showed you, at week 192. So 1 in 5 women is going to get it. For that, you're denying the treatment for many women. So I don't think that would be a issue. The second is based on baseline obesity, whether I would use dolutegravir in an individual who is an already obese guy. But again, these studies really show that if your baseline BMI is low, you have a higher chance of weight gain.
Right.
But that is, I think, a mathematical statistical flaw, because obviously you will be seeing more weight gain happening in that context.
Sure.
So maybe in that population, maybe you can think of it, but I would more focus on trying to advise something for the obesity of that person.
Which is a more liver-friendly ART in naive populations?
Well, liver-friendly ART, reasonably, of course, integrase inhibitors are quite liver-friendly. And we are not talking about in the background hepatotropic viruses co-infection or in the background of AKT, because there were studies looking at using HIV in HIV HBV pregnancy. There was this promise, there was this impact study which was presented in Montreal, which looked at treating HIV HBV in women who were pregnant, and they treated it with lopinavir ritonavir based regimen and a DTG based regimen, and they didn't find any difference in efficacy as far as virologic suppression was concerned, but there was a higher proportion of liver enzyme elevations which were seen. So when you have comorbidities, when you are having anti-TB drugs going on, then obviously you will have higher liver enzyme elevations. But in a clean naive patient, integrase inhibitor should be okay. Efavirenz reasonably okay. Nevirapine is a no. Nobody uses nevirapine nowadays.
So I think when it comes to giving HIV or ART in pregnancy, the earlier there was a there was a concern of neural tube defects or with dolutegravir, but I think in the last 2-3 years shown that the risk is not as much. Do you see in your experience that dolutegravir is taking over efavirenz, to give to pregnant women?
Yeah, so all guidelines have changed, including the WHO guidelines. As you know, the comprehensive ART guidelines now suggest, irrespective of whether a woman is in reproductive age group, to take dolutegravir as a first-line regimen. So even the US guidelines, even the EACS and BIVA, everybody support using a DTG in the reproductive age group female. And we are not really, but there are caveats. Many of these guidelines do mention discussing it with the women, the theoretical risk or the small risk, and then deciding based on that.
What is an alternative to doxycycline in PEP for those who don't tolerate that doxycycline?
Well, we don't have any other studies for that. And even I would not suggest using doxy right now. It's just an interesting study. Keep an eye on it. This is an interesting field emerging.
So was there any Indian data presented at this conference?
Indian data, not sure. I'm not sure I saw anything interesting, but should be there. There were, I think there were data on more on, because this is not just a clinical conference. So there was data on prevention, socio-behavioral issues, particularly injection drug use. I saw a lot of data on, I think the Sunil Solomon group from Chennai. So barriers to access and things like that. So not much clinical data.
So what is the relevance of continuing efavirenz in light of the NAMSAL study results?
Yeah, so I think we may see a revision of the WHO guidelines as far as durability is concerned. Again, that is something which is based on the baseline viral load. In that population, there is a concern. If it is more than 100,000, the durability of efavirenz 400. But when it is less than 100,000, there's not much difference, even at week 192 with efavirenz 400. We definitely know 400 has less neuropsychiatric adverse events as compared to, and now there is some PK data also to suggest that you can perhaps use it safely with rifampicin.
Great. So, almost all the HIV vaccine trials have, are shown very discouraging data. I think the major challenge is, of course, the speed or the mutations in the HIV. So, what do you think will be kind of groundbreaking? What should we look for, in a vaccine development?
Yeah, so there are multiple challenges for developing an HIV vaccine apart from the mutation. But most importantly, I think in spite of the mutations, there are certain epitopes on the surface protein of the virus which are conserved across variants. And if you have, but these are covered by the glycan shield, so they're not easily visible to the immune system. But fortunately, in a small proportion of individuals over a long period of time, neutralizing antibodies are formed against these conserved epitopes. There are 8 neutralizing epitopes on the which have been identified on the surface protein of the virus. And the whole idea now is to try to develop broadly neutralizing antibodies. These are called broadly neutralizing antibodies. And the proof of principle for that came in the ACT studies, which was published in the New England Journal some time ago, which looked at a monoclonal antibody VRCO1 for kind of a pre-exposure prophylaxis. So infusions were given monthly or 2 monthly, I don't remember, or 3 monthly. But that showed in the overall population no decline in HIV infection. But in the population where the virus was sensitive to VRCO1, there was a dramatic decline. So it's not just one antibody, but you need to have a combination of broadly neutralizing antibodies. And the challenge is to try and induce them, to which immunogens to use, how to develop those immunogens. And now I'm certainly seeing interest in the mRNA platform to deliver these antigens.
What would be an ideal ART for a patient with HIV cholangiopathy who has high bilirubin and transaminitis?
So if it's a proven HIV cholangiopathy or cholangitis, AIDS-associated cholangiopathy, I hope it's not CMV, MAC, those are the differential diagnoses for that. Then I don't see any problems in any of the integrase inhibitors because these are not cirrhotic patients. The problem with using these drugs, there's very limited data for use of these patients in cirrhotic patients, particularly with the CP staging B and C, where data is very limited in terms of safety. So I think it should be okay to, and then treat the cholangiopathy if needed by stenting, etc.
Has there been any progress in monotherapy for HIV?
Monotherapy?
Yeah,
so monotherapy has consistently failed. In naive patients, I don't see any monotherapy with the currently available drugs. When we are talking about currently approved drugs, there are 34 approved drugs now since the beginning of the HIV pandemic. I don't see any monotherapy for naive patients being beneficial. There were experiments made with using dolutegravir monotherapy as maintenance, and that also showed high virologic failure rates and development of resistance to dolutegravir. So it was not just virologic failure, but failing with resistance.
In a patient with co-infection of HIV and HCV, can we start treatment for both simultaneously, or should we take it step by step? And any recommendations on what regimen to use?
So there is no issue. HCV iris, for example, is not a very well-defined entity. Remember, HCV is not usually an immune-mediated disease. It's a viral load-mediated disease, unlike HBV, which is an immune-mediated disease. So you may be able to, as soon as it's not, because now HCV treatment is very easy. You can, across genotype, treat it with the one pill once a day, and duration is based on whether you're cirrhotic or not. So there is no difference in terms of outcomes if you start them both together or not. We don't have trials for that, but I don't see any reason why you should not be starting them together.
At what level of serum creatinine and EGFR should we reconsider about TAF 25 and TAF 10?
So either way, you use TAF10 only with the boosted protease inhibitor. TAF25 otherwise is used with your non-boosted protease inhibitor regimen. So it would be a standard thing that when you have a fixed dose combination available, you can't really cheese that out. So creatinine clearance of less than 30 is some situations where you would start avoiding. In fact, avoiding for preventing progression of the disease, and if a patient has an underlying CKD as a cause for the decline in the creatinine clearance.
Okay, a couple of questions again from my end. I think when we look at some data coming out from monkeypox, it's not an STD spread by close contact, but yet we see around 97 to 98% of the patients are men having sex with men, and also I think 51% of them have HIV. So is there a predictive so will those docters who treat HIV will there be a chance that they see more, they observe more monkeypox, and should they be aware of this?
I think it's a MSM population predominantly, and unfortunately, about 50%, as you said in the New England Journal, I think it was the UK cohort, they were positive for HIV. There is a debate going on because of the atypical features of monkeypox, because enogenital lesions, single ulcers on the genitals, all those things were never seen in the endemic monkeypox situation. So there is a debate going on whether you should consider monkeypox as an opportunistic infection in HIV. But remember, all these HIV patients in the cohort in the New England Journal were actually well suppressed. They had good CD4 counts. So we really don't have the answer for that now. But I think you should keep an open eye in your practice to. So the idea here is that even a single ulcer, a genital ulcer coming to you currently, somewhere back of the mind, you should have monkeypox as a differential. But of course, with the proper epidemiologic link.
And also, I think in UK, I think men having sex with men have multiple partners compared to heterosexuals, though. So maybe that also is playing a role.
Yeah. So I mean, heterosexual anywhere in the world, MSMs tend to have more partners as compared to heterosexual. So I think it's a universal issue.
So what is the, going on from that, I'll come to a question about COVID as well. Based on your experience, so we've seen that, third dose is usually given to those who are immunocompromised, so who are taking immunosuppressants or who has had a recent organ transplant. Do you think people with AIDS or HIV should also get a third dose for better protection, or they can just follow the normal guidelines for which is given to the general population?
No, I think this is a little complex issue, but to really simplify it, currently it is widely believed that 3 doses is defined as full vaccination for anybody. So it's irrespective of whether you're HIV or not. And even the government program today in India is recommending it for every adult, the third dose. So it is not necessarily initially started with elderly population with comorbidities and some special populations, but now it is for everybody. So you should consider 3 doses as full vaccination. The question is the 4th dose. And the 4th dose uptake in the US, currently they are recommending it for elderly population, immunocompromised host, etc. And they're also moving towards a bivalent vaccine, as you already know, the Omicron versus plus the ancestor variant. Yeah. So I think the 4th dose is something which needs to be debated about.
Okay. So what is the protocol for dealing with a possible false positive HIV test? Can we how can we rule in or rule out HIV? So one of the participants in this webinar is saying one patient tested positive in August at the government facility. He was referred to a specialist institution for the management of anorectal mass. Then he tested negative for HIV through the 4th generation tests. His HIV RNA test turned out to be not detected. He has no risk factors for HIV and his partner wife is negative. So can you?
Yeah, so this is the problem with the not following the algorithm for HIV testing. The algorithm for HIV testing starts with the 4th generation ELISA. The 4th generation ELISA is more specific. So if the 4th generation ELISA is positive, then you do a rapid test to differentiate between HIV 1 and 2. So starting with a rapid test and then not following up with a confirmatory test, you may have these problems. But best is to start with a 4th generation ELISA. And if it is positive, then reconfirm it and different with an HIV 1-2 differentiation assay.
What are the other options for a third-line failure on in a patient receiving darunavir with ritonavir and dolutegravir?
So this is highly unlikely that this third-line patient would really have resistance. So I would look at doing the resistance testing for both the protease as well as the integrase genes and see if there is really any resistance. You may be able to, because right now we don't have options for multi-class failures. Truly, honestly, in our practice, we don't see such patients. DTG plus darunavir, ritonavir, third line failing with resistance. It's more of a problem with adherence, more of the problem because these two drugs are costly to be taken together and patients may not be taking the recommended doses. Maybe a problem with using darunavir once OD, once a day, when you have significant darunavir associated mutations at the end of second line. And maybe you're not using the BID dosing, rather than that you're using OD. So all of these other factors need to look into. Otherwise, then of course in the Western world you have ibalizumab and things like that, but we don't have that.
Does the chickenpox vaccine have any protection for monkeypox?
So one of the ideas was that in the waning immunity, because of the original smallpox, I don't see any chickenpox vaccine data. I'm not really sure about that. I can't answer.
Any luck with the P24 AG test?
Separate P24 antigen test. The HIV 1, 2, 4th generation ELISA has a P24 antigen.
Okay. So one of the participants, he is looking to switch from dolutegravir to bictegravir in a patient with the issue of weight gain, but he has some kidney issues. So what do you suggest?
I don't see any reason why an individual would be shifted from DTG to bictegravir for weight gain purposes, because that is not going to really change the weight situation for that patient. There's not much data on that, but all these second generation integrase inhibitors have similar weight gain problem.
Okay. Sorry, coming back to that, any luck with P24? I think Ananda was asking, the false negative test that she was experiencing in her patient, and then you answered by not following the algorithm. She was asking whether a P24 AG test would help.
Yeah, so 4th generation is where you should start with, and the 4th generation has the P24 antigen. That's what I was saying.
All right. Okay, Ananda, I hope that answers your question. Sorry, we're getting a flood of questions right now. Hard to keep up. Has Cidofovir been successful in treating monkeypox?
Yeah, so there are options which have been tested as antivirals. Cidofovir, I think Brixidofovir, yeah. And there's another drug I could forget to.
Monkeypox, I think
Tecrovimat or something.
Yeah, is the
so
short.
These are the 3 antivirals. Yeah, so these are being studied. I'm not really sure in terms of reducing the duration of symptoms. And most important thing that they are finding is pain. Pain is a very significant issue in monkeypox lesions. And there where a lot of supportive treatment is needed for this patient.
So, I mean, from my reading, I've seen that in US, the TPOX is called, it's a nickname for the, so I forget the drug as well. That has been rolled out quite a bit. And you're right about pain. I think in the UK, 10% of the those who have monkeypox have been hospitalized for pain. I mean, even the painkillers were not enough, so they had to be given some kind of morphine or something to rid of it.
It is tecovirimat.
Yeah, right.
But I have not seen a monkeypox in my practice. So
Okay. So one of my patients is suffering from HIV and rheumatoid arthritis. He's taking methotrexate tablet. So may I know how will it impact her immune system? Will there be any chances of opportunistic infections?
Yeah, so in the situations where immunosuppressive concomitant drugs are used along with the antiretroviral treatment, you have to, normally what we used to do in the non-immunosuppressive concomitant treatment situation is stop monitoring CD4 count once their viral load is undetectable and the CD4 is above 350. So we don't monitor CD4 counts currently. We just monitor viral loads. But in the immunocompromised concomitant situations, CD4 monitoring is very important. And if the CD4 count falls, the screening for cryptococcal antigen as well as initiation of prophylaxis with TMP SMX is very critical. And that is why monitoring for both is needed in this context.
Which drugs are you looking forward to, in addition to the long-acting cabotegravir?
Looking forward for what?
I mean, you're excited about maybe in a development phase, but you think it's going to change the game or something?
Well, I think that changing the game will be only long-acting drugs, which have long half-lives. Okay. So if you are able to take an oral tablet once a week, or if you are able to take an oral tablet once in longer durations, that is where the game is perhaps going to change. Injectables, we know that injectables long-acting are already available, but the problem with the injectables are also there in terms of injection site reactions. And these injectables are usually being given IM. So the patients can't take IM injections. So they are looking at the PK of IM versus subcutaneous, so that patient can self-administer these at their homes. They don't need to come to the clinic to take an IM injection. And the PK of a subcutaneous cabotegravir with the IM is also quite promising. So I think the only game changer would be long-acting drugs in terms of, otherwise what is left in HIV?
True, that's true. Okay. So I think before coming live, we discussed this, but I think some audience would be interested to know. Till last year, even I was quite excited about islatravir with the long PK, but suddenly all the trials have stopped. So could you just throw some light on it?
Oh, they are suspended because they found lymphopenia in the group, and currently the development is suspended.
What is an alternative treatment for patients with CKD with raised creatinine? Should TDF be continued?
No, obviously you would avoid TDF if the GFR is less than 60 ml per minute ideally, particularly in the CKD situation. You can go for a 2-drug regimen, a DTG 3TC. The problem with the 3TC dose adjustment for lower eGFR is also not there currently, because there are a lot of observational studies suggesting that you don't need to really adjust 3TC dosing because it's not a very toxic drug, unless and until your eGFR is less than 50 and 15 ml per minute or something like that. So in kind of a stage 5 CKD.
In your experience, how many patients do you come across with HIV cryptococcal meningitis? Is it a very prevalent thing, and do you have some idea about the incidence in India?
Right now, we are seeing quite a less of cryptococcal meningitis. Not right now, for years now, we have not seen much cryptococcal meningitis. Once in a while, we may have a patient. This is because of the ART. So with the ART, your CD4 count is gone up, and you really don't develop these opportunistic infections. So It's quite rare to see cryptococcal meningitis in our practice, at least. Maybe patients who have virologic failure on ART, maybe patients who have stopped their medications, maybe patients who have been diagnosed about 20 years ago and never followed up with us, coming with the incidental cryptococcal meningitis. These are the rare groups of patients who may come to you with cryptococcal meningitis.
So I have a last question. You expressed your desire for all the doctors to come ahead and really advocate for cabotegravir treatment to come into India. I would like to draw on that, and maybe just another point, for those who have been unfortunate enough to not get an opportunity to go to IAS, maybe just one or two main take-home, kind of messages from the conference that we would like everyone to know.
One or two, I showed you the implications for practice slide for all the three aspects. I think the exciting aspect, but no access, I think, is the rifampicin resistant TB short course 6 months treatment. I think this is an exciting opportunity. And maybe even companies like MCure need to look at whether they can get drugs like BPAL. Of course, linezolid is already available, but bedaquiline and pretomanid in the private markets as well. Of course, the rationalization of use and all those things will be there. But that is one very exciting area of a dramatic practice changing thing. The other aspect is I think prior to rolling out any injectable ARVs for treatment, I think it would be interesting to conduct a study amongst our patients to find out what their preferences are. What is the acceptability? What are their thoughts about an injectable drug? For you may find that 90% are okay with taking one tablet daily rather than coming once in 2 months to the clinic and getting themselves injected with an IM drug. So I think patient preferences involving the patient community is very, very important before we try to, impose on them that, okay, you have an injectable available now and you should be using it. Otherwise, I think it's quite a small incremental things that we are seeing every conference, and it builds on the science. It also reassures us that what we are doing is perhaps on the right path, evidence-based. So I think it's a good thing.
Okay, I'll invite Mr. Balaji to come in right now. And thanks a lot, Dr. Pujari. This has been very informative. Thank you.
Thank you, Dr. Rohan and Dr. Sanjay. It was a very nice evening that you have been able to concise the 5-day conference very nicely in your presentation. Even for a person to have physically been at the conference and to be in and out of so many sessions, to go through this many trials and studies would have been very, very difficult. And your insights into these studies are very interesting and thought-provoking, and nice to have been with you, and you being on this webinar on this Saturday evening for your time. We are very thankful for your time, and I'm sure we have been having a record number of logins for this session, not only from India, but also from other countries in Thailand, in Nigeria, in South Africa, and Kenya. And I'm sure all those who have missed out coming to the conference for whatever reasons, they would find this very interesting. I'm sure we would also be circulating the recordings of this for those who have missed this live session. So thank you once again from the entire Conquer team, and we are thankful, and have a good evening, doctor.